Hello, I'm Gerald Finken, and I'm CEO of RxE2. Today, I'm going to be giving you the second in a series of webinars that I'm going to continue talking about E2 dispensing. Today, I'm going to be talking about pricing. RxE2 is a company that's incorporating the practice of pharmacy into clinical research, and you're going to find out what that means specifically for the dispensing and the cost of dispensing for clinical trials. So the last webinar, I talked to you about the patient-centric supplies and the importance of that, why E2 dispensing is so unique. And today I'm going to talk about ARR pricing, which is really the pricing that's used by the software as a service model. So it's like a subscription-based pricing. And we look at this because, and I'll get into it, that because of the uniqueness of E2 dispensing, we're going to really disrupt the way we think and work with clinical supplies and clinical trials. So let's get started. I think it's important to start with where we were, and that's traditional packaging and labeling. You know, for 40 years we've been doing it this way. And it's an interesting model that worked, but it did have some of its, and still has some issues that we need to face. One of the things we know is that when you do traditional packaging and labeling, you prepare in bulk, and that is you can prepare 25, 50, or 100% of the supplies up front. So before your study even starts, you have inventory ready to go for your studies. The issue with that is these forecasting overages. Now, in my lifetime, most of the time, it was always the rule of thumb 100% overage. But as we got better at forecasting and then doing multiple runs, you know, like do 3 batches, you could get down to 50% overages, but of course then your costs are 3 times as much for paying for that packaging and labeling operations. And of course, one of the things too is that, you know, project management, it's all about the timing. How long is this going to take? Usually it's like a 3 to 6 month process from the time you start planning until the time you actually have supplies in inventory ready to go, even if it's down to the 50% and you only have like 25% of your supplies available. And the last thing, of course, is really taking a look at the fact in the depot and site usage, because again, that was another part of the waste that we had to deal with. There was the in-house waste and the site waste. And then 20 years ago, I created the OnDemand packaging and labeling, which I talked a little bit about before. And that was really focused on what we can do to eliminate the waste. You know, drug supplies were getting more and more costly. And I was looking to see more and more supplies get destroyed that were never used. And it just really bothered me. We spent all this time and effort to make these clinical supplies, and at the end of the study, we're throwing a lot of them away. So really, the whole idea of this is that we really wanted no upfront packaging and labeling. So we do all the preparation, but packaging and labeling wouldn't occur until we got a shipment request. Versus in traditional, all the packaging and labeling take place, and then a shipment request would come in. The other thing, of course, with this is that it eliminated all the warehouse waste. If you haven't packaged and labeled to your shipment request, there's nothing to throw out. And that was a very interesting concept at the time, 20 years ago when we introduced this. Today, everyone's getting so much better about novel ways of how to use the on-demand concept. Of course, along with the on-demand, I then backed that up 20 years ago with the direct-to-patient shipping model to say, wait a minute, where's the rest of our waste going? 25% of the waste, approximately 25%, is at the clinical sites. So we'd send them 10 kits, they wouldn't enroll a patient, 10 kits get destroyed. Or if they enroll 2, 8 kits get destroyed. So we're always trying to balance how much to send to the sites, the clinical sites. So I said if you used on-demand and direct-to-patient, you eliminate 50% of the total waste, or you don't have to do 100% overage, you just do what's planned for in the trial. And you know, that was key to the on-demand and direct-to-patient. So now I'm introducing E2 dispensing. And so what this is, as again in my previous webinar when I talked about this as really on-demand and direct-to-patient combined, but on steroids. It's taking it to the next level. And when I created this, I was really starting to incorporate the practice of pharmacy into the GMP environment. But now what I want to do is I want to move it out of the GMP environment and into the GCP environment. And I'll talk about that in a second. So in the GMP world, what we do is we keep the entire dispensing under the auspices of a GMP facility. So it goes to the, from a manufacturer, right, to this under GMP. We'd send it to a package label site under GMP. We send it to the clinical site under GMP. And that clinical site then hands the GMP material right to the patient. So if you think about that, which always got me thinking about it is, wait a minute, in the commercial world, we have GMP materials going to a pharmacy, and that pharmacy then dispenses according to state laws. But the GMP ends at the pharmacy. So can you imagine if it didn't? You'd go to the pharmacy and they'd hand you a bottle of 1,000 or a bottle of 100 tablets with the market label on it, with the commercial label. It would make any sense to you, would it? That's not patient-centric, as we talked about before. So if we move it into this environment, we move it to the GCP world, or where we follow the commercial environment where the GMP material, right, goes directly to a pharmacy, then the pharmacy takes over following state pharmacy laws, which then dispense directly to patients. So in essence, you could say clinical sites could receive the bulk material, and we do it all the time with unblinded pharmacists, that then dispense materials in their facility. Now the issue is the complexities if you did that to each individual clinical site. Where with my E02 dispensing, we have a central pharmacy that can actually send clinical supplies to every state, to every independent, or to every clinical site, or directly to the patients in any state, because the central fill pharmacy is licensed in those states. So in essence, this E02 dispensing is pharmacy dispensing. And of course, when I want to say the issues, what I love about this is over the years, there were so many things that were difficult for us to overcome. And I remember one of the key things was adaptive by design. There's two reasons why that process never really worked. One is we couldn't get the data clean fast enough. And two is the costs were exuberant from clinical supplies. Why it's stated that they did 600% overages to try to compensate for this adaptive by design. In this E2 model, this could happen every day. The patient get a new medication each week, each 2 weeks, each month. It's really no issue at all. So let's get into the key part of this. Besides timing and planning and all that, the key that I want to talk about in this, as we talk today, is, and I'll get the timing in another webinar, just pricing. So in traditional model, I remember the work orders, there was like 50 some line items of expenses that you had, from receipts, storage, startup, and you can read all these things to get to, right, the price in traditional to kits in inventory. Now in my on-demand model, I had a problem with pricing because these prices were known and I could compare, but I wouldn't know how much to produce. For instance, here, this has 1,000 kits, and you know how much it costs. But over in the on-demand, if the study never starts, this cost is never seen because there were no kits sent because the study never started. But yet, in the model of on-demand, I was forced to try making this kit and this kit, the pricing the same so people could look at it. So, like I always said, on-demand costs more per kit, but overall costs less because you're going to use 50% less of the supplies. Anyhow, it was an interesting concept, and I hope many of the people address that pricing. The issue for me is, in this model, it wasn't just there, because in the on-demand and traditional, sorry, just a second. There we go. In this traditional on-demand, there's still other prices, like the shipping. And this is where the direct-to-patient now really is changing the way we think about decentralized clinical trials, what's happening. In the traditional model, again, and in on-demand, they're the same. These are prices about what it would cost. But now with the direct-to-patient, because this would go to a clinical site, on-demand was going to a clinical site. The issue now with direct-to-patient, using either on-demand or traditional, is the cost sometimes are 6 times as much. These pass-through costs of shipping direct to the patient, because of course they're shipping to each patient versus, like 1,000 patients versus 50 sites. So obviously there's cost so much more. But when you look at that, that really then prevents us from doing a lot of these centralized clinical trials. So I want to simplify it. let's go to E02 dispensing. Again, working with the practice of pharmacy. And so what we're going to do is we're going to rethink the way we price things and use this ARR pricing, annual recurring revenue pricing, a SaaS model, and just charge a monthly fee. So like I mentioned, you can get up to 50 shipments per month, or dispensings, because you dispense and ship, it's all one, and it's $15,000 per month. The key is it's all inclusive. It isn't in the modeling before trying to match on-demand to traditional or one vendor to another. This is it. It's $15,000. That's the only thing you need to compare, and everything else is included. Isn't that simple? Isn't that simple? Now you say to yourself, wait a minute, come on. How is ARR pricing possible? How can we say $15,000 a month knowing the costs? Again, what we've got to take a look at is what are we doing? We're taking it into the commercial world. Instead of us taking the clinical supplies process and then throwing it over the wall to commercial, and they run whatever they run, we're going to bring the commercial process and the practice of pharmacy into the clinical trials. And the more we do that, the more all prices are going to decrease. So in this model here, in the commercial model, we start commoditizing. Because a pharmacist dispensing, it doesn't matter the cost of the drug. For me, it was like 2 minutes per prescription. If it took me more than 2 minutes, I wasn't moving, especially on a Saturday morning. And pharmacists today, they handle prescriptions that quickly. And what does that dispensing include? Taking it off the shelf, the bulk product, counting out tablets, labeling it, quality assurancing it, dispensing it, and counseling the patient on it. You know, all in 2 to 3 minutes, because the counseling takes a little bit longer, and the longer counseling, maybe 4 minutes. 4 minutes we're talking about. So if you think about that, we can commoditize that because we know what the prices are for a pharmacist. We know what overheads are for pharmacy. And so when we go to dispense, pharmacists know, how much they make per dispensing. And you go to the internet and say, how much does a pharmacist make per dispensing? In this model, then it's commoditized. And the key is about time. We're not talking in this model. You go back here into this here. Like I said, all this takes 3 to 6 months. This took 3 months plus the day you wanted to ship. All of that was much more than just coming to this and saying 2 minutes, 4 minutes. It's just that simple. So anyway, I hope this taught you some interesting information and that you like it and that you'll stay tuned for my next presentation when I get into some of the FAQs. I think that's my next one, about the FAQs of the specifics about E02 dispensing. All right, thank you very much and join me next time.